This activity, CME activity, has been planned and implemented by the Southern Alliance of Physician Specialties, CME, and HVC. The Southern Alliance is accredited by the Medical Association of Georgia to provide CME credits, and I have no relevant financial disclosures. So again, this is a serious discussion. The goal is to provide attendees with the latest useful information that we could all take back to our practices. So something we all deal with is the health insurance companies. So we need to learn more about the terminology they used and maybe make a little light of them. So I've prepared a guide to health insurance company denials, otherwise known as things insurance companies say, but what do they really mean? An official sounding term that health insurance companies say is medically unnecessary. They define this one way. We could define this as a life-saving treatment deemed optional by someone with no medical degree. Another term we love to hear in denials is experimental. So what do they mean when they say experimental? What they're really saying is a treatment that might actually work, but hasn't been tested on enough unpaid claims to be considered cost-effective. Something we all hate hearing, we always hear, we didn't receive the records. So what does this mean? What are they really saying? So after we've sent 200 pages of records, they somehow are missing one record from the day the patient was born. Yet, these same companies, they have actually never lost a record for a missed insurance premium payment. And everybody loves hearing the infamous, you can always file an appeal. So what do they mean by this? They're basically saying, listen, we know you're as busy as shit, and you don't have time to wait on hold for 45 minutes. So I'd like to continue this dictionary with another term we're hearing more and more. This is not evidence-based medicine. You have a denial. What they're really saying is there's overwhelming evidence that approval will cost us a ton of money. And patients hate hearing this. Your policy doesn't cover that disease. They're basically telling the patient, you have lung cancer. That sucks, and you need chemo, but those drugs are really expensive, so we really can't help you at this time. But feel free to file an appeal, which we just heard about how that goes. Another process they use is the peer-to-peer process. When they do this, they're basically saying this is a process in which a non-practicing physician with no training in that specialty, but excellent training in how to maximize profits, reviews the claim. And then for all our admin and billing folks out there, the pre-authorization, which basically is a guarantee that the insurance company may not pay the claim. So thank you very much, Again, welcome to the Atlanta Cardiovascular Symposium. I think we have an incredible lineup. Thanks to Shasta and Penny and Rod for helping organize this and put this together. Really could have done this without their support at this very nice venue. Our first speaker is Dr. Meghna Anugu. She's an assistant professor of medicine at Emory University School of Medicine. She's board certified in internal medicine and obesity medicine. I was really excited when I spoke to her because I like the way she uses the concept of food as medicine to treat and prevent metabolic disease. She's going to show us how she uses AI tools and even ethnic preferences to develop diet plans. So I'd like to introduce Dr. Anugu.
All right, well, thank you so much for having me here today. I will tell you that I've been a practicing primary care physician in an academic setting for 5 years now. My motivation and interest in food as medicine really comes not only from my professional stories with patients, but also personally. I've struggled with weight lifelong, and in my first pregnancy, I gained 50 pounds, and it really shook me up when I went to my OB appointment, and she said, yeah, you're gaining too much weight. You need to eat more vegetables and do a food log. Spent 5 minutes with me and left the patient encounter. And so that's when I took a closer look at the food I was eating, the macronutrient distribution, and kind of the evidence base that surrounds food that promotes optimal health. And so when people use the term food as medicine, it's really this philosophy that the food you eat can prevent, treat, manage chronic disease, and promote health. And I have no formal disclosures to report. My goal today is to really review the basics of nutrition, take a slightly deeper dive into eating habits that promote cardiovascular health, and go over 2 clinical cases. I want this to be interactive, so feel free to raise your hand, shout out comments, thoughts, questions throughout. I will tell you, patients often come to me very specifically with, hey, what do you think about CMOS? What do you think about this vegetable supplement I saw? And I often respond by saying, hey, let's take a step back. That's a good question, but I want us to take a time out for a moment and look at your general eating habits. What is your understanding of eating habits that promote good health? And so I often ask patients the question, what is in your food? And patients often look at me kind of dumbfounded, not sure how to respond. And I give them kind of my 5-minute spiel. I tell them, listen, we eat food to give our body energy, to nourish our body. On a fundamental level, food is made up of nutrients. Macronutrients imply that you need these substances in larger amounts. Micronutrients implies you need these substances in smaller amounts. Most people are aware of macronutrients, and in the fitness community, a lot of people will talk about counting their macros, right? Carbohydrates, proteins, fats. There's also a lot in the media about certain micronutrients, vitamins, minerals. What we don't talk a lot about is phytonutrients, phytochemicals. These are things that are only found in plants, and they are substances that help with plants' immunity. So think about it that when you eat plants, you reap those same immune benefits. So I literally will draw this on the exam table paper, and I will ask patients to give me examples of what they think these things are. Before we move on, you might wonder, well, how does fiber fit into this? How does water fit into this? Fiber is a type of carbohydrate. It is essential for gut health. It is unique, though, because you don't actually digest it. It goes through your gut. Water is also a nutrient that doesn't have caloric value, but it's essential for hydrating your body and to do certain biochemical reactions on a cellular level. So carbohydrates. Can people shout out what are examples of carbohydrates in the audience? Bread, rice, pasta. What's that? Yes, I'm hearing a lot of bread, rice, pasta. Yes, definitely. What's that? Fruits, yes. And so when you think about carbohydrates, they are categorized based on their chemical structure. So simple carbohydrates are mono or disaccharides. And these are things like glucose, fructose, sucrose. These things are found in fruits, table sugar, corn. And so in America, when you purchase processed foods, most of the sugars are coming from fructose and glucose that companies derive from corn or cornstarch. Complex carbohydrates are basically longer chains of monosaccharides. These include starches, glycogen, and fiber. It's really important for people to understand the difference between simple and complex carbohydrates. The reason we care so much is because we know simple carbohydrates and refined complex carbohydrates, they raise your blood sugar higher and quicker than their whole grain or complex carbohydrate counterpart. I know a lot of people mentioned pasta, rice, bread. So it's funny, I'll ask a patient, where does pasta or bread come from? And people won't know. Do you know where pasta or bread comes from? Wheat, yes, wheat. Wheat, there's rye, there's different grains. Generally in America, when you go to a supermarket, it comes from wheat flour, right? And I think about when I was a little kid and I went to my grandparents' farm, they have rice paddies. And so literally rice, the people will go and get the rice grains from the field, right? And so when you look at the grain in its original form, it's made out of 3 components. The outer bran, which is full of fiber, vitamin B, a variety of other minerals. The germ, which is like the seed, and that part contains a lot of vitamins, minerals, protein. And then the endosperm, which includes the majority of the starchy substance. So when someone goes to a store and picks up a whole grain item, that item has retained all 3 parts, okay? When someone picks up all-purpose flour or white bread, what happens there is that the manufacturer has removed the bran and the germ. So you lose a lot of the fiber, minerals, vitamins. And so that is what a refined carbohydrate is. So technically, when you think about rice, think about brown rice that has all 3 parts, and then think about white rice. The company has removed the bran and the germ. So technically, they're still both complex carbohydrates, but because you've lost the fiber, when you eat white rice, it raises your blood sugar higher and quicker than brown rice. What does enriched mean? Do you ever go to the store and see bread that says enriched, like enriched white bread? That means that the company has removed the bran and the germ, but they've put some of the vitamins and minerals back into the product. But when they put the vitamins and minerals back in, usually it's not more than 50% of what is in the original form. So you're gonna get the biggest bang for your buck if you eat the whole grain. Okay, so a little bit about protein. Protein is made up of amino acids, and the average patient I see in my practice is low to middle income. And typically when I ask patients, what do you think of when you think of protein? They'll say meat. And meat tends to be a really important part of their culture, lifestyle, upbringing. And what I like to educate people on is, hey, there's also protein in plants, and specifically legumes. Legumes are things like lentils, nuts, seeds, soy, tofu, edamame, that kind of thing. And in terms of animal protein, different kinds of meat, eggs qualify as protein. Okay, in terms of fat, so the first branch point I talk about is the difference between saturated versus unsaturated fat. Saturated fat typically comes from animal products, red meats, beef, pork, etc. And it also comes in things that are like solid fats and oils, so butter, ghee, ghee, butter, there's something, lard, yes. And so for my average patient, the red meat component tends to be really high. In terms of unsaturated, it's important as clinicians that you recognize there are two types of unsaturated fats: monounsaturated and polyunsaturated. Does anyone know what monounsaturated fats look like? Maybe Pavani? Yes, avocado, olive oil, exactly. I always thought that because poly means more, it means it's better. That's not necessarily true. It's really important to have both monounsaturated and a certain ratio of polyunsaturated. So when you think of monounsaturated, think of olive oil, avocado, exactly. And in terms of polyunsaturated, I'm sure you are all aware of the terms omega-3 and omega-6 fatty acids, right? What I didn't realize is that it seems like there is a sweet spot in terms of the ratio of omega-3 to omega-6 fatty acids that people should consume, okay? It seems like it's ideal to consume a 1-to-1 or 1-to-4 ratio of omega-3 to omega-4. We'll get into that a little bit later. But omega-3 fatty acids, super important, especially for heart health. These are found mostly in fatty fish. Fatty fish include salmon, mackerel, herring, sardines, and anchovies. They're also in walnuts, in some nuts, but just not in very high quantities. Omega-6s, we see them a lot in seed oils. So when you're trying to counsel patients on their diet, I think it's important to understand what they're cooking with. Good, and trans fats. So there was a lot of media attention on trans fats when I was growing up. This is stuff like that if you look on an ingredient label, it says partially hydrogenated oils. In America in 2015, the government said, okay, yeah, these things are bad because they really elevate your LDL, triglycerides, and increase atherosclerosis. And so they said, companies, you have 3 years to stop making this. But technically, if a food has less than 0.5 grams of trans fat, they can still on the ingredient label list it as 0. And in different countries, they've had a similar narrative. Like India, they banned trans fats in 2018 and said, as of 2021, you have to stop using them, but it's hard to really reinforce. And so I would encourage you, when you look at ingredient labels, if it says partially hydrogenated oils, probably stay away from that processed product. Okay, so we talked about different macronutrients. How do we know how much is actually needed in your day-to-day? So this fancy organization, the Food and Nutrition Board, that is under the Institute of Medicine, they create dietary reference intake. And so they have generally, the latest edition, they've outlined what is recommended in terms of percent of total calories. For me, it's hard to think of percent, and so I've created a column where you can see how many grams per day is needed based on a 2,000 calorie daily intake. But the thing is, as a busy primary care physician, are you sitting there calculating this? Probably no. And so I will give you some tools in a little bit to talk about how I broadly go over this. Okay, so we talked about macronutrients. Let's talk about micronutrients. I am 100% sure every one of you has had patients come in, bring in a supplement and say, is this good? Right? And I have found this resource incredibly helpful. This is like a Wikipedia for micronutrients. This is created by National Institute of Health. They have an Office of Dietary Supplements. So if you look at the top right, if you just Google NIH and then any vitamin mineral supplement, usually the first link that will come up is that supplement plus health professional fact sheet. You click on it, and this is the beginning. It kind of breaks down in a Wikipedia format of recommended intakes based on your age, gender, the summary of evidence, and what is kind of the bottom line. So I found this extremely helpful. And I would encourage you after this lecture to look at the information, Google omega-3 NIH, because that literature is really interesting. Did you know supplements, you probably do know, supplements are not regulated by the FDA. They are considered a food, right? And so there's kind of an honor code system. There are laws and policies in place that say you have to follow certain good manufacturing principles, but no one's really enforcing them. And there's been a lot of studies that show what's listed on the bottle as the dosage may not be exactly the quantity that's truly in there. There's large discrepancies. So what is helpful to know is that there are third-party entities where manufacturing companies can hire them, and these entities will come in randomly and test the products, okay, and ensure, okay, these are safe, they're following the good manufacturing principles, and the doses that are listed are truly in them. The three reputable companies I trust are NSF, USP, and Consumer Labs. So if your patient feels strongly about using supplements, I would recommend that you ensure they are certified by one of these entities. Usually it will be listed on the bottle, but sometimes you have to actually Google it and it will be listed on the manufacturer website. I know for a fact Nature Made products are USP certified, and also Kirkland products are. Oh, but the thing is, remember, supplements, they don't have to prove that the dose they have is actually effective for their intended health, effect. So this is where it's helpful to look at the NIH website to see what dose of omega-3 is actually helpful for what patient, and give patients a little bit more guidance. The other last thing about supplements is a lot of times they're complexed with magnesium or other things that cause diarrhea and loose stools. So a lot of times I have new patients coming to me with horrible IBS symptoms that started 10 years ago. It's because they're taking 10 supplements and which have an insane amount of magnesium in them. Okay, so we kind of foreshadowed on the principles that help promote cardiovascular health. Today is not meant to be a biochemistry lecture, and you've probably heard all of these buzzwords, but just to reiterate, the literature shows that eating foods in its original form, so less processed, mostly plants, and being intentional about the types of fats you eat, prioritizing monounsaturated, omega-3, polyunsaturated fatty acids, and choosing lean protein options, such as poultry, fish, over the red meat. These are the basic principles that promote good cardiovascular health. And these are the principles that are defined in the Mediterranean and DASH diet. Unfortunately, the American diet historically is not in line with this. And I spend a lot of time counseling my patients on the basics of this. To get a little bit more concrete, I created a chart looking at the exact percents recommended of the macronutrients in these different diets. I think what I really want to point out is the saturated fat intake should be less than 10 or 7% of your total macronutrient intake. And in terms of fiber, whoa, look at this, 27 to 37 grams per day in the Mediterranean diet and 30 grams per day in the DASH diet. I want to compare that to what we've seen in terms of weight loss and what people have talked about in mainstream media. There's a lot of dialogue surrounding low carbohydrate diet. So you can see that the carbohydrate percent is lower compared to the Mediterranean and DASH diet. There's a bigger emphasis on protein in low carbohydrate diets. And compare this to the low-fat Ornish rosemary Conley diet. This is something that's more in line with the Mediterranean DASH diet. I feel like there's so much emphasis on protein and not a lot on the quality of the foods you're eating. What I'm getting at is look at the average weight loss when people are on low carbs versus low fat. It's similar. People talk a lot about protein, but I think the emphasis really should be on the quality of plant foods they're eating. And you can see that individuals can be successful on a Mediterranean DASH type diet. I like bringing this infographic up to my patients. So we talked about how protein can come from plants and animals, right? The thing with animal protein is the main source of saturated fat. This is what Dr. Bott is doing in his clinic, putting stents in, trying to open up those plaques. And you see vegetables, they have no cholesterol generally. Some tropical plants do, like palm oil, but really for the most part, plants don't contain cholesterol. The other thing in animal protein is you just don't get any fiber. With plant protein, generally, you get a significant amount of protein, fiber. And so I like bringing this up just to show people the differences. I particularly love edamame. That's a great snack to have, like the dry roasted or frozen that you can get bags at grocery stores. I've had a lot of patients love that. We wanted to take a closer dive on animal products. So let's look at steak. It says 4 grams of saturated fat compared to beans, black beans, 0 grams of saturated fat. Okay, so, and then in chicken, there's 1 gram of saturated fat. It's interesting, you might ask, well, look, steak, the total fat is 11 grams. What is that other 7 grams? It's probably unsaturated, right? Unsaturated fatty acids in animal products, it tends to be more atherogenic, create more inflammation. I have a few clinical cases. These are real patients I've seen. And I want to give you some tips, tricks, tools that I use in my practice. So I recently met this 42-year-old female. She's an epidemiologist at the CDC. She's 11 months postpartum, busy mom. Her husband is currently living in South Africa doing some work. And she was diagnosed with gestational hypertension and she continued to have it. So now it's chronic hypertension. She has mixed hyperlipidemia, PCOS. She actually has a remote history of Roux-en-Y gastric bypass. Her BMI is 41. And her main concern is she wants to talk about weight. These are her medications. And she has a full-time job, by the way. So a huge tool I often use that's been game-changing in my practice has been asking people about what did you eat in the last 24 hours. It will give you a concrete snapshot of what they've done to date. I found that if you ask people generally, hey, what are your eating habits like? They kind of say, oh, I eat a lot of vegetables. Yeah, I go out to eat like once a week. And it doesn't give me a lot to work with. So this doesn't seem all that bad, right? She had coffee with almond milk, white rice, black eyed peas, collard greens. It's important to understand portion size. And this is a tool that has been really helpful in my practice too. It's your hand. And the biggest measurement I use is I clench my fist and I say, this is about a cup, okay? Can you estimate for me how much white rice you ate? And the other thing is the palm of your hand is 3 ounces. This has also been helpful in quantifying food. The distance between your thumb tip to the interphalangeal joint is 1 tablespoon, and then a tip of your other digit to the DIP is a teaspoon. So it's been really helpful in me getting a more concrete understanding of their eating habits. So we went through this, and I have some like venti Starbucks cups in my office that I show people to get an idea of their food intake. But she's able to quantify now, okay, this is what I ate. Okay, And I often stop there and I say, hey, what do you think about your eating habits? And patients, they're pretty insightful. A lot of times they're able to pick out general themes. So she told me, Dr. Anugu, I don't think I eat enough vegetables. But I think that like what I'm eating is good, like I'm not going to McDonald's. So the next thing I do is validate. Yeah, you're doing great. You're a busy mom. I'm really impressed. I want to give you a general tool to help you create meal plans in the future. And these are 3 different models that I often reference. The USDA is the one on the left. The middle is a slightly revived version by the Harvard School of Public Health. And the one on the right is created by the American College of Lifestyle Medicine. So generally, I literally draw this on the exam table sheet. I draw a circle, I cut it in half, and I say 50% of your plate should be fruits and non-starchy vegetables. And people will say, what are starchy vegetables? Does anyone know what starchy vegetables are? Corn, potatoes. Yes, corn, potatoes, green peas, hominy. And the South hominy is huge. That's what grits are made out of. So if you're eating those starchy vegetables, I put them in the grain category. Okay? So I say, okay, 50% of your plate is fruits and non-starchy vegetables. If you're eating starchy vegetables, it goes in your grains. Grains, and I ask them to tell me, what do you think of as grains? Bread, pasta, rice, yes, those go in a quarter of your plate. And then a quarter of your plate is protein. If you're vegetarian, this can be plant protein, right? Nuts, legumes, lentils, seeds, tofu, etc. If you're not, ideally I want this to be a lean type of meat. This simple model has changed my practice. I tell people when they leave, listen, when you come back, I just want you to remember Dr. Anugu's sitting on your shoulder when you create a meal, and whenever you make a plate for yourself, 50% of it should be fruits and vegetables. I think that's just the beginning, right? That's just a very basic principle. And the thing is, we often get stuck at the grocery store buying the same things week to week. It's really important that you mix it up because every plant has a different, unique micronutrient profile. You're gonna get different benefits eating different ones. So I also often tell people, eat the rainbow. If you Google USDA vegetables, they've categorized vegetables based on their macronutrient profile. And sometimes I'll print out this sheet for patients just it helps them understand what vegetables they may be missing and what they should be targeting. I have these sheets, these are available online. This is from the American College of Lifestyle Medicine. It's called a superfoods sheet, but sometimes I have patients tell me, Dr. Anugu, I don't like any fruits and vegetables. I will pull this out and I will say, okay, I'm gonna go call a patient, you fill this out. And they literally check off everything they like. I come back in and I say, it seems like there are some options we can work with. And it just helps continue the dialogue. So this patient's a busy mom, right? And so also, a lot of my patients are low to middle income, so I always reiterate to patients, listen, I use frozen and canned foods where it's easier, it's more accessible, etc. It is okay. Actually, frozen foods, did you know they're picked and frozen at the peak of the season, so they have a higher micronutrient profile than when people grow them outside of the season. So I'm a big fan of frozen vegetables. Canned, the main thing is just making sure it's low sodium, sodium free. And I think a lot of people get stuck on, is it organic, not organic? And I think it's a spectrum, right? Eating a not organic blueberry is better than eating like blueberry jam, right? So everything is always a spectrum. So I always tell patients, let's take a step back. Okay, so Are you familiar with open evidence? Is anyone? This has changed my practice. It's been a game changer. So if you don't know, open evidence is an AI platform that specifically uses peer-reviewed, evidence-based information from medical journals. And so I often, based on my patient's level of health literacy, I will type in a prompt like this. And because sometimes patients, they want more than that my plate model, okay? They're really interested, Dr. Anugu, like, tell me how many grams, this, that, and I say, listen, let's just do a snapshot, okay? I don't want you to fixate on this, but let's just see what are some general themes we can work on. So for this patient, I entered in open evidence, create a chart of macronutrient distribution based on the following patient's 24-hour diet recall. Also include a column with fiber and calorie amount. And so for her, look at the fiber, 14 grams. So it's, in terms of optimizing her heart health, I think that's a place we can work on. And look at her amount of polyunsaturated fats. It's not that high. I think for her, those were the two big things that came out to me. And so I sometimes then use open evidence to have a conversation with the patient, and the patient will, I often ask the patient, what do you think about this? And she told me, you know, I think I'm interested in increasing my fiber. And she said, you know, I do like brown rice quinoa. I can incorporate that. I don't like fatty fish, but I can do an ounce of walnuts. So she came out from that encounter saying, okay, I'm gonna include an ounce of walnuts. And yes, I like your idea of just making sure the percent of my plate, a higher percent is vegetables. She was eating collard greens, but just not enough. She was only having half a cup a day. My last case is of my dad. My dad is the worst patient. So this is a picture from a few years ago, and you can see his metabolic belly that he says is good for my baby. But it is a reflection of his mixed hyperlipidemia and the fact that he probably has fatty infiltration of the liver. He has OSA. He just found out he was pre-diabetic. I forced him to get a sleep study, but he doesn't use the CPAP. I forced him to start a statin, but he takes it maybe once a week. So anyways, this is what my dad drinks. He eats 3 to 4 cups of chai a day. And then he loves white rice. Okay, we're South Indian. So 1 to 2 cups of white rice with every meal. My dad does love vegetable, but you can see it's probably not at that 50% guideline. So for him and so for some patients, they're not really interested in changing their eating habits significantly, right? What do you do in a patient like this? So if I ask my dad, Dad, what do you think about your eating habits? He'll say, I like sweets. I like my Indian sweets. I love my chai. And so it can be tough having patients like this where they're not in the headspace to make changes. But I think in terms of motivational interviewing, what's been helpful is to focus on the things he does like. So for him, he really loves vegetables. So I think that if you tell someone to increase their vegetable intake, the other things will naturally decrease. I found that people don't respond well when you go to them and tell them, stop eating sweets, stop eating the laddu, stop eating the fried mixture. So that's one thing I've talked to him about. It's really important to understand our patient's culture and background, right? So my dad, and for many of my other patients who are from different parts of Africa, the my plate model doesn't really work. Like growing up in India, my dad didn't eat avocados, right? And so there's been a lot of really interesting infographics available through open evidence in the American College of Lifestyle Medicine. So I would encourage you to explore. I also think sometimes in a patient encounter, if they're from a country I'm not familiar with, Like I had a Filipino patient once whose hemoglobin A1C was greater than 12. I asked Open Evidence to give me some examples of diabetic-friendly Filipino foods, and I found that the conversation was really helpful. So this is my dad's macronutrient distribution, but what I'm trying to highlight here is that I don't think this is a great I don't think Open Evidence did a good job here, because I don't think it understands that my dad probably each sweet has like 3 tablespoons of ghee or butter in it. So this is not perfect by any means. So for him, I really focused on increasing the vegetable intake, and in doing so, increasing the fiber intake. And we had a discussion about fiber in general. How can we increase his fiber? If you made one change, switching from white rice to brown rice, that could increase his fiber intake 4-fold, but he said no, he hates brown rice. So I said, what about parboiled rice? Because that's a manufacturing technique where they remove the bran and germ, but they do something where they boil the grain, and so part of the nutrients and fiber comes into the endosperm. So it tends to have a lower glycemic index than eating white rice on its own. I have included some high-yield resources that I found helpful. This is a topic you can talk about for years. You can do a PhD on this. Someone I just learned about is Dr. Mary Sko. She has a website with really great patient handouts, nutrition-pharmacy.com, which I would encourage you to look at as well. And then this is also available for free on the American College of Lifestyle Medicine. A lot of patients, for different reasons, don't want to start a statin. I know, I'm sorry. And so I found people respond well when you say, okay, well, your homework is XYZ. This is what we talked about today, and physically giving them this prescription. So thank you so much. And I think we're out of time, but thanks for your attention.